benefit and toxicities from aromatase inhibitors? Well, if you think about it, for the medical oncologists in the audience, that's what you do every day when you sit down with a patient to talk to them about their options for therapy. So I'm going to go through basically some of the facts that go into my database when I go in and talk to a patient to try to inform her. And so except for the last several slides which relate to pharmacogenomics, most of these slides you'll be very well aware of, but let's go through them. I have no conflicts of interest. On a talk about balance, I'm still amazed about Philippe Petit walking between the twin towers of the World Trade Center. So balance. Well, as background, when you're thinking about benefits and toxicity, obviously you have to think about age. And obviously you have to think about comorbidities because, as you know, they affect the balance of benefit and toxicities. Eksterman, back about 10 years ago, looked at life expectancy in years. And so we all use this. So you can see the 65-year-old woman who's healthy has a 2-decade life expectancy. The woman who's sick, and in this study they actually used IBCSG trial 4 criteria, let's say an MI, that woman has half that period of life expectancy. The best of all cases, a healthy 85-year-old woman has a 6-year life expectancy. So these are the types of things we integrate into our thinking about when we see a patient. Now, Mary Charlson combined age and comorbidity into a score, and actually this paper influenced Peter Rabden's Adjuvant Online considerations, as we'll see shortly. And there were 10 different comorbidities she added, and she had a nice formula that calculated those. But you can see in the right panel that the higher the age comorbidity score, the lower the 10-year survival. Okay. The effect of comorbidity on 3-year survival in early breast cancer was looked at by Satariano. And basically you can see that the level of comorbidity, if it's 0, the ratio of breast deaths to other deaths in this study was 4 to 1. So there was a higher likelihood of a woman dying from breast cancer than other causes if there were no other comorbidities. But as you can see, as the level of comorbidity increased, in fact, this ratio decreased so that the likelihood of a breast death, the proportion of breast deaths related to other deaths was very, very low in the women with, say, 3+ comorbidity. So, Judy Ann Chapman looked at Paul Goss's MA17 study a couple years ago and looked at competing causes of deaths from a randomized trial from MA17, the extended adjuvant. And basically, she looked at the 5,100 patients. As you can see, the median follow-up was 3.9 years. And she looked at 11 baseline factors and correlated those with breast deaths, other malignancies, or other causes. And it's interesting that 60% of the deaths in MA17 were non-breast cancer deaths. And you can see for those women over 70, almost 3/4 of the deaths were non-breast deaths. So, and she looked at the baseline factors, and the bottom bullet is cardiovascular disease was associated with other causes, as you might expect. Alistair Ring in JCO several years ago looked at the experience with ATAC, and you can see the left panel is deaths without recurrence by age. And you can see the blue line at the bottom in the left panel. Women less than 60 had a relatively low rate of deaths without recurrence, and it went up progressively with increasing age. You can see that the reddish line over 75 had a substantial rate of deaths without recurrence. Now, Dr. Ring looked at deaths without recurrence according to this Charlson Comorbidity Index, and again, that was very influential. So, dying from breast cancer or non-breast causes depends on a number of things: age, comorbidities, the factors of the cancer, obviously, and the expected benefits from therapy. So those are the types of things that we think about when we sit down with a patient in our office. Well, this was about, I think, 4 years ago that the St. Gallen guideline first basically supported Adjuvant Online as a tool for clinicians to use when they're seeing patients. And it was pointed out at that time, this is a validated tool. And so, you know, as I would assume that most people in this audience who take care of patients, medical oncologists at least, have used this. And you can see circled in blue is the comorbidity. And so taking this 70-year-old woman, you can see she's got about a 15% risk of relapse, and you can cut that relapse rate in half, as you know, with aromatase inhibitor therapy. But if you add just one level of comorbidity, you can see that because other deaths increase, your risk of relapse goes down, and your potential benefit, instead of being a half, is closer to a third. Now, this is not news to anybody, but it's the importance of comorbidities that we have to take into account. Well, on the benefit side, this is Mitch Dowsett's publication from a couple years ago, the aromatase inhibitors overview group, and I just took the monotherapy comparison, tamoxifen versus an aromatase inhibitor. And basically, you can see that everybody knows the p-value was significant. And also of importance is that deaths without recurrence, there was no difference. And if you look at a forest plot, according to the different ages in terms of benefit, there does not appear to be a difference between the younger postmenopausal women and the older ones. So I would propose that on average, that the balance favors AIs in terms of benefits. Well, you can take this a little further. The STEPP analysis of 5-year disease-free survival in Big 198, and the composite measure of risk was ERPR, Ki67, and HER2. And if you look at this composite measure of risk, you can make the case, well, in the lowest risk category, in fact, the data suggests that the balance is pretty equal in terms of efficacy between the AIs and tamoxifen. But the value or the advantage for AIs over tamoxifen is better in the intermediate and highest group. Well, Dr. Goss recently published online the experience with MA27, which was a randomized trial of exemestane versus anastrozole in postmenopausal women. If you look at the summary of the patients, you can see that patients who discontinued either of the aromatase inhibitors, 16% went off for AE, adverse events, off other illnesses 3%, and refusal was 4%. As you know, refusal is often due to some adverse event. The total is about 1/4 of the patients on this study went off treatment because of adverse events or other factors. A mirror, looking at about 30,000 of the patients entered on aromatase inhibitor trials, comparing AIs versus tamoxifen, published his meta-analysis in JNCI several years ago. And the interesting thing about this is that they expressed the results as a number needed to harm. And so the main findings here is that AIs were associated with significantly increased cardiovascular disease with an odds ratio of 1.26, number needed to harm 132. As we all know, AIs in the older studies were associated with bone fractures, but now we pay attention to bone health, but odds ratio 1.47, number needed to harm 46. There was also, even though this only involved, hypercholesterolemia only involved 4 studies, the odds ratio was 2.26, and it's statistically significant for higher hypercholesterolemia in AIs. And as we all know, venous thromboses, endometrial cancer are lower. No difference in cerebrovascular disease or other cancers. In their meta-analysis, death without recurrence for AIs trended towards being higher with AIs. So let's just look at the cardiovascular events, because I think these are of the greatest concern to those of us who have said, well, maybe women ought to take AIs for longer than 5 years. Well, this is from the US FDA, and basically here was from their package insert, stated the following: ischemic cardiovascular events between, and this was from the ATAC trial, anastrozole 4%, 3% tamoxifen. But in women, in the black box, women with pre-existing ischemic heart disease, an increased incidence of ischemic cardiovascular events was observed with anastrozole, 17% on anastrozole, 10% on tamoxifen. And so they suggested considering this when you talk to patients with pre-existing heart disease. I might say, if you look at the label for letrozole and exemestane, these don't appear. And Dr. Colioni, I think, has a nice article looking at toxicities from Big 198 and similar results. Overall, it didn't appear to be any difference in cardiovascular events, taking all cardiovascular events. There wasn't anything statistically significant for ischemic heart disease, but I believe the wording in the article was there was a trend towards it. So at the bottom line with respect to adverse events, cardiovascular adverse events, they appear to be small in the general population, but they may be substantial in those with pre-existing heart disease. Okay, I had the pleasure of being on the NIH Consensus Conference about 20 years ago, and this was the conclusion that we made at that time. Adjuvant systemic therapy for discussion with the patient talked about the risk of recurrence without adjuvant therapy, expected reduction with adjuvant therapy, toxic effects of therapy, and impact of therapy and quality of life. And I think we really, as we do this, when we look at the balance between benefits and risks, have to be aware of the role that comorbidities play. Clinical judgments required, as quantifying competing risk is actually very difficult, and patients are interested in absolute benefits. Okay, I'm going to, in the last minute, just say a few words about clinical observations with endocrine therapy. Clearly, there's variability between patients in terms of response, adverse events, and obviously differences in outcomes, striking differences in some AEs like musculoskeletal events. Some people can be incapacitated, others don't have any problems. Differences in DVTs, hot flashes, lipid effects with tamoxifen. So genetic variability most certainly plays a role. As you know, pharmacogenomics is a study of the role of the host genome and individual variation in drug response phenotypes, disease response, and organ effects, including AEs. Our first study in this looked at the most common reason why women went off MA27, and that was musculoskeletal adverse events. And we published this several years ago. And basically, Drs. Offit and Robson said it was a new pharmacogenomic paradigm. And I want to just say a word about this pharmacogenomic paradigm. A GWAS, you take DNA and you run it on a lot of patients. At the end of the day, you end up with SNPs, and you end up with a p-value. Well, that doesn't tell you very much. You have to relate those SNPs to some function. You have to relate that function to impact on genes, and then ultimately, how do these genes interact with drug effect clinical phenotypes? So I won't belabor this, but basically in our first study, we found SNPs near a gene, TCL1A. We showed that those SNPs, SNP-dependent, there was expression of inflammatory cytokines, basically IL-17, the Th17 type cells, and ultimately NF-kappa B was the expression of that was elevated. So this provides a pharmacogenomic explanation for an important adverse events, but we have a lot of work to do to bring this value to patients. So my conclusions are, AIs offer substantial benefit to postmenopausal patients with ER-positive disease. On average, AIs offer a better benefit-risk profile than tamoxifen. AIs are associated with AEs in a substantial proportion of patients. Pre-existing ischemic cardiovascular disease is a comorbidity that decreases the potential absolute benefit from AIs. Musculoskeletal adverse events represent a major impediment to their use. Attention to bone health, lipid status are indicated. Pharmacogenomics offers the potential for contributing to individualized therapy, but this remains to be proven. Thank you.